Good evening and welcome to the first panel discussion in our fall 2021 series, examining the longer-term impacts of COVID in our state and beyond. The University of Rhode Island Academic Health Collaborative and the Interprofessional Education and Practice Initiative have again coordinated this panel series. I'm Dr. Anita Jacobson, a pharmacist and clinical professor in the College of Pharmacy. I am also the program director for the Community First Responder Program, which provides overdose education and resources, including naloxone, to rural populations throughout Rhode Island. Tonight, we'll be looking at the pandemic's epidemic, the crisis in mental and behavioral health. On October 20th, the panel discussion will focus on COVID and kids. And our final panel on November 3rd will examine the critical role of healthcare teams in supporting COVID patients with complex pre-existing conditions. Please note that all the panels this fall will be recorded and available on the URI Academic Health Collaborative website. So I would like to introduce tonight's panel. Jonathan Gorey has served as an expert advisor to the Governor's Overdose Prevention and Intervention Task Force since its inception in 2015. He is also a co-author of the state's strategic plan to address overdose deaths and has been instrumental in the expansion of naloxone distribution and utilization of peer recovery specialists throughout the state. Currently, he serves as the director of the Rhode Island Recovery Friendly Workplace Initiative. But perhaps most importantly, he is an overdose survivor and a person in long-term recovery. Munira Khan is a full-time ANCC board-certified psychiatric nurse practitioner at Butler Hospital, Patient Assessment Services and Psychiatric Emergency, where she assesses, diagnoses, and treats individuals that present with emergent psychiatric needs. Additionally, she owns her own practice, Remembering You, Psychiatric and Therapeutic Services, and also works closely with a private practice called United Paths. As a Nigerian American, Munira has taken time to understand and study the biases, stigmas, and struggles underrepresented multi-ethnic individuals and groups face, and utilizes that knowledge in creating a treatment atmosphere that assists in the healing process for all of her patients. Dr. Jeffrey Bratberg is a pharmacist and clinical professor of pharmacy practice at the University of Rhode Island. He studies the essential public health roles pharmacists play regarding opioid safety, opioid overdose, harm reduction, and opioid use disorders. And he advocates for their increased role in medication access, public health promotion, and policy change. He co-teaches an interprofessional Grand Challenge course on opioid use disorders at URI, is an associate editor of the Journal of the American Pharmacists Association, and proudly serves as secretary of the Association for Multidisciplinary Education and Research in Substance Use and Addiction. Dr. Hector Lopez Vergara is an assistant professor in the URI Department of Psychology. His program of research is funded by the National Institute of Health to investigate cognitive, motivational, and environmental mechanisms in the etiology of mental health problems. Dr. Lopez Vergara's program of research seeks to unpack specific dysregulatory risk factors for psychopathology and substance use, with an emphasis on executive functioning, reinforcement sensitivity, and memory processes. He is also interested in social determinants of health, specifically on the need to explicitly test for equivalent instrument functioning when making inferences across historically underrepresented groups in science. And Dr. Trudy Ann Gale earned her doctorate in clinical psychology in 2011. She is a licensed clinical psychologist based in New York City and a senior staff psychologist at a nursing facility there. She is also CEO, co-founder, and clinical director of Life Matters Psychological Services in New York City. There they provide therapy and related services to a largely minority population of couples, individuals, and families. And I'm excited to begin this evening with our first question. And also, as participants have questions, please enter them into the Q&A, the question and answer box, and we will be taking questions from the audience at the end of the program. So I would like to start out with our first question, and we're going to give an opportunity for each of you to give us some insight into your professional experience over the past year and a half. And we'll start with Jonathan.
Hello, everybody. Thanks for having me. My name is Jonathan Goyer, and amongst the many capacities and hats and roles that I play, most importantly, I am a person in long-term recovery. And what that means for me is that I haven't used a substance or alcohol since June 17th of 2013. Unfortunately, that is not the case for a lot of other individuals. In my line of work, the overdose crisis that we're seeing, the accidental drug overdose crisis, is just through the roof. Rhode Island saw a 25% increase in 2020 when compared to 2019. And this year, again, we're seeing a 12% and higher increase in 2021 compared to 2020. So we're looking at, in the last 18 months, about a 36% increase in fatal drug overdose deaths. That's impacted my work tremendously. In addition to that, a lot of the COVID regulation left treatment and resource capacity actually minimized, unfortunately, and I'm sure you'll hear a lot about that tonight. And parallel to that, a higher demand, right? Because we've seen more people have a reoccurrence of substance misuse in the last 18 months than we have ever in history that we have documented. So it's there's no shortage of work, to say it lightly. And with my work as director of the Governor's Recovery Friendly Workplace Initiative, working with them has been particularly hard. So it's an initiative that provides support for employers to foster a recovery-friendly workplace environment, make resources more available to them. But with the ever-evolving COVID guidelines and regulations put onto businesses across all industries has left them unable to engage as much as we would have liked to see. And another area that I'm very passionate about is peer recovery, the peer recovery workforce. Here in Rhode Island, we call them certified peer recovery specialists. This time has been very, very hard on them as well, too, frontline workers. So we're seeing a significant workforce shortage in frontline workers. And just on a personal note, it's been hard, right? It's doing the work of helping people every day and making a difference in people's lives is very, very rewarding. And it's fun to do when you're seeing an impact. But when you work for 18 months straight and you're seeing actually numbers get worse, it's just, to be honest, it's hard. Some days are hard. But we do what we do, and I've got a tremendous amount of colleagues that I work alongside that do this work every day. So with that, I'll pass it on to the next panelist.
Munira, would you take it from there?
Yeah, sure. So as mentioned earlier, I'm a board certified nurse practitioner and I work at Butler Hospital. And just to sort of echo a little bit about what we've sort of seen during the past year and a half, so 18 months, COVID pretty much is a precipitating factor for a lot of the presentations of the individuals who present to our emergency services. We do notice, and we have seen a pretty significant trend in individuals who are struggling with substance abuse and other co-mental illnesses as well. For instance, I've had patients who, were sober for 2 years prior to COVID-19. And then as a result of the pandemic, job loss, multiple other stressors that they probably would have been able to manage if they had the, ability to go to an AA meeting or, reach out to individuals that they could actually meet with that could help them continue with their journey in sobriety. But I've noticed that more and more Now I know that there are more in person, but during the time when we really didn't have access to all of that, there were a lot of individuals who were consistently relapsing and really struggling in order to regain their sobriety. Other things that, we've noticed a lot of children as well presenting. So I think that there's so many things that the stay-at-home order in the beginning, although obviously well-intended and necessary and needed, caused a pretty significant amount of stressors for individuals who didn't have really good food security, individuals who may have had really difficult situations at home. And then financially too, I think that we'd see all of those particular areas that have been affected as a result of COVID-19. And so our hospital census for the last 18 months has been pretty much full. We have an overflow unit that we are consistently open on a regular basis. And even in my outpatient practice, I am seeing daily individuals who are coming, talking about the struggles with having to sort of, work with what's going on because of COVID-19 and how it's impacting their overall mental health, not being able to socialize, the fear and the anxiety that it has placed in a lot of individuals. I think I am seeing more and more of that and needing to treat it on a regular basis. And so between addiction, children, and then other populations that a lot of people haven't really talked about are individuals who may have been, are sexual offenders. And so for those who may have had some sort of like internet pornography charges of nature, they're not really typically able to utilize the internet, and it's usually a part of their, probation or whatever the case may be. And so I found that I was actually seeing a lot of individuals who did not have access to treatment, right? Because for the most part, a lot of providers were treating individuals virtually. These individuals can't have access to internet, and they oftentimes don't also have data on their phones and things of that nature, but nonetheless are individuals who need to be treated. And I saw a lot of that as well, coming into our, emergency services for ongoing treatment. And then the part about it that really was difficult was sort of like, what's that follow-up going to look like? And so the increase of recidivism into the hospital and the turnaround, I mean, we were seeing discharges that were happening and then individuals returning within a week or a week and a half, just because there was no good aftercare or follow-up that could be put in place. A lot of psychiatric practices, both those that are affiliated with organizations, have wait lists. They just don't have the capacity to continue to take on new patients while also trying to balance their own mental health and take care of themselves. And so it's been tough. It's been really hard. And I'm sure the rest of you all will echo similar sentiments, but that's pretty much what we've been seeing over the last 18 months. I think in my private practice and certainly at Butler, we've been struggling to just sort of, manage the need, meet the need, while also, ensuring that we are adequately staffed, because that's also been a pretty significant issue during this COVID-19 pandemic as well. So I'll pass it on to the next provider.
If it's okay for me to jump in here, because I'm hearing so many of the things that I've experienced over the last 18 months, both working in the nursing home and having a private practice, it's that we have the demand. The demand is great. Our phones are constantly ringing with people who are in need of services. They are experiencing burnout from being at home, homeschooling children, burnout at work because they're essential workers or frontline workers, and we just can't meet the demand. I can't tell you how many ads I've posted and just tried to recruit good clinical staff to meet the demand.
Oh, we may have had
demands of all the patients, all the children that are calling, and what's going on. And we just can't find good clinicians who are willing to stay on or who understand what the demand is and are able to rise to the occasion. And if there's one thing that's really important to us as a practice is providing good clinical care and just having good integrity in terms of follow through and follow up with our patients. And we just haven't been able to do that. And so I've had to jump in and land on both feet. When I do more of the administrative work, I do some clinical stuff, but I do most of the administrative things. And I've just had to jump in, and I'm seeing clients around the clock, sometimes till 11 o'clock at night, just to help and help who's calling, so that they're not, they're saying that they're calling places and no one's answering the phone. And I think that that's been the consistent thing. And that translates right into the nursing home, where the patients are also saying, hey, I haven't spoken to anyone. No one's visited, because the nursing homes were on lockdown for about a good 15 months. I think they just reopened here. And so the isolation of not being able to see a family member, not being able to do, activities, and then the staff is out. So where they had a connection with a staff member, they don't have that anymore. And for a while, even the clinicians, psychologists, were locked out of the facility because of just heightened precaution. And so they had no one. Thankfully, we had telehealth, which kind of met the need, but it's not the same as in person. And it took away a lot. It was a good supplement for the time, but it took away some of the meat and potatoes of really what happens in a clinical interaction. So I think that's been the case for me down here in New York. Just demand versus finding good clinical staff, or feeling burned out yourself, or being locked out because of a facility. That's what I've been facing. So I really hear you, Jonathan and Munira. It's been a tough 18 months for us. So
Hector, we'll go to you as our next panel.
So my name's Hector. I mostly am on the research side. Before the pandemic, we were running a research study to try to understand a phenomenon that has been called deaths of despair, which is sort of like a weird thing that the lifespan of the average American has been on the decline even before the pandemic. And that's attributed mostly to addictions and other types of mental health problems. That research was shut down from the pandemic because it was no longer safe to interact with people face to face. We have relaunched this study. I thank URI for giving me the resources to relaunch this in the COVID era. And we're starting to get underway, but we're moving slower than we used to. And again, we're trying to understand what are some of the risk factors for deaths of despair, which again, a weird phenomenon from my perspective, because we know from epidemiology that adolescent substance use is like the lowest it's ever been. Like drinking has been going down. I mean, marijuana's been steady, but relative to like the 70s, 80s, 90s, adolescents are doing a lot less drugs. But for some reason, somewhere after the end of adolescence to 20s, 30s, 40s, something else is going on that at the population level, excess drug use and mental health problems is, for the country, decreasing our average life expectancy. So that's kind of how the pandemic has treated me.
And Jeff.
So much has been said. I'll try to be brief. I agree with everything that's been said. I think as an academic, I think I saw these last 18 months, really, I've been teaching for almost 20 years, but I think I've really changed how I've taught, not just on Zoom, which is beneficial and not, just like telehealth, but also sort of forgetting about deadlines and asking students how they feel, not being critical, really understanding where they're come from. I feel sometimes bad that it took a pandemic to be like, oh, we're all affected by this, and be like, oh, they always were affected by things, in a steady trend of increasing anxiety, depression, psychosis, perhaps that drug use that they get after adolescence in college, which is not usually sustained. So, and college students are different than non-college students in terms of drug use too, or people who go to college who don't. I study overdose, I study harm reduction. I also have research studies. I had one research study get greatly limited by COVID, but we still did it, and I'm proud of that. Another study, COVID was an opportunity, where we said, wow, they've relaxed, and we're going to talk about this probably later, but they relaxed access. They allowed greater access to medications for opioid use disorder like buprenorphine. And so Rhode Island is the site of the greatest number of people started on buprenorphine in what we call a no barrier pharmacy model. And so this is a nationally funded model where people can get access to treatment instead of waiting 2 weeks. You know, I hear my colleagues here talking about waiting for mental health, and it's like, you can't wait for mental health. You can't wait to get naloxone and all the achievements that Dr. Jacobson's study has done and service has done. So I think we just see that we need more than just naloxone and medications and counselors and telehealth. We need to solve those social determinants of health, and we need employment and recovery employment, and people, you know, no longer can the social stigma of behavioral and mental health be just a checkbox in that introduction to a paper that 4 people are going to read. Like, we all need to understand it. That's the point of these things, is to say, we've got to address this. I'm starting to do it in my teaching and in service to say, you know, and Dr. Jacobson taught me motivational interviewing too, to say, like, find out where the person is. And I think Jonathan and others would agree, meeting people where they're at, and where they're at is not good, whether they're a healthcare worker, a person who was in recovery, a person who's returned to use, a person who never had a mental health problem. I mean, one thing that I worry most about is long COVID, which causes up to 30% of people to have not only physical problems, which always have a mental component, but actual massive increases in the incidence of anxiety and depression among people who had no risk factors. And I don't know if that's supported by my colleagues, but are you seeing lots of new patients that were, I don't know, I could make a lot of categories. You mentioned youth, but moms who no longer work. And
absolutely.
That's my biggest worry, you know, and there's disparities within those women too, of course. And so there's this huge sort of tidal wave you see in the distance of this mental and physical health for an already overwhelmed healthcare system, already itself burdened by people who don't accept their own. I mean, I had mental health problems during COVID, and I didn't realize until I started reading about it. I'm like, I think that's me. Yeah, I should take care of me. And I did. And it's like, go in nature, end class early, go do yoga with Dr. LeMay, you know. Exercise really is important. And as a teacher, to tell that to a group of students, I feel the best about, because sometimes I know when you're in that room with one patient or in with your colleagues, or Jonathan talks about the peer recovery specialist, we had this great conversation about, are we really paying everybody the right amount? Because I worry my students are not going to go into healthcare, or all of our students at URI or other places, because they're going to say, I don't like being that burned out. Or we know COVID is going to be some kind of thing, or the next COVID. And so I think I turn that into a positive to say, advocating for our interprofessional work, whatever technologies, and not just meeting people where they're at in one format. You know, let's put AA online. That was good for some folks. Doing counseling for your methadone online, giving people a month's supply of methadone. Ended up not being a big deal. Okay. Other than more people lived, we think, right? I think that's supported by the data. So sometimes there's innovation in crises, and we need to keep innovating, and we need to really not necessarily have new ideas, but also say, hey, there's this old idea of like, let's have everyone have mental health first aid, and let's have everyone be first responders, and let's give naloxone to everyone, and let's make PUP as most available as possible, and make sure that we're all looking out for each other and our families, and understanding this massive, this societal change is happening right now, and we need to watch it.
And Jeff, I'll also sort of echo too, in my private practice, as a result of, you know, being able to do telehealth, I'm seeing less no-shows. I'm seeing so many more people just sort of addressing their mental health. And I think that there's, you know, this notion that once, you know, the world fully opens back up and more people are vaccinated, that, you know, how is that going to affect people getting the treatment that they need to get? Because people are constantly juggling and balancing so many things. Outside of the fact that we already know that so many like moms, dads, family members are not working or employed, how are they going to be able to now get to these appointments, right? And so we have to think about like the long-term risk factors of just sort of like removing the ability to have access to the treatment. And sometimes that access is, yes, being able to get on your phone and click on that link, you know, and be your provider so that you can get the treatment that you need. Specifically too, I think that, you know, as long as when we talk about the long-term effects of COVID, right? A lot of individuals, as you mentioned, who have no pre-existing, you know, health or medical conditions, who've had COVID, are now like dealing with this like chronic fatigue that's leading to a lot of anxiety, that is leading to a lot of like mental fog and depression, and really needing to be able to treat that and trying to figure out the ways in which we can do that effectively and appropriately.
Absolutely. I think being here in New York City, and I think we were hit really, really hard in the early months. I think many people developed a lot of anxiety and depression surrounding not knowing what's going on outside,
Okay.
what's happening outside. And we felt so, you know, I had a no one in, no one out order in the house. Our babysitter wasn't able to come in, no one in the house, no one out, because I don't know what's happening. Is this thing falling from the sky? What's happening? Why are we losing so many people? And that created anxiety. My husband lost significant amount of weight just from worrying. His mom got COVID, his grandmother got COVID, my uncle, a few family members passed away. And so that alone and the isolation with deaths and not being able to have the closure just to attend a funeral service was really, really upsetting and caused some long-term effects for us as a family, because we weren't able to, you know, gather and console each other. And that still carries over. It's 2021, that happened in 2020, but we're still talking about the death that we had, that we weren't able to attend a funeral, and we had to watch it via Zoom. You know, my family members locked out in another country and weren't able to return. So there was a lot going on here. And I'm sure in other places too, just a lot of anxiety and people just not knowing where to turn, what to do. And so that started the beginning of the phones really ringing. Once they realized, okay, this is what's happening, they started to call for support, which I'm grateful for. I think that before that, I didn't know if people knew that the supports existed, but they started to press that button and say, hey, I need an appointment. And they started seeing me from their car or from a bedroom or anywhere that they could, just to say, I'm struggling. Can you help me? Can you talk me through this? My grandmother just passed away. She was in the nursing home. Or my uncle, he's in the hospital in ICU. Can you walk me through this? How do I deal? How do I cope? So I think we're going to see the long-term effects of it. And I myself have felt it as well, just being very transparent.
I mean, I hope that what more people who've experienced, you know, we have let's just say we have 1 million COVID deaths, which I think is an underestimate in itself. It's about 640,000 deaths in the US alone. And then you think of every family member around that. And I know Jonathan and I have talked about, and Anita and I've talked about this, you know, every single overdose death has a circle around it. So every single COVID death has a circle around it and around it and around it. We're all touched by this. I mean, look at how many touch points you just mentioned, Trudy. I mean, that's just astounding, but not, that's happening everywhere. And all those people, it's great that people are pressing that button for need, but we know that a significant portion of people have substance use disorders that don't get treatment. We know that there's probably more of those people. And then there's people with mental health that don't know what it is. And then there's a whole bunch of people who have no mental health who are also not diagnosed, and people not able to get care. And so I think the mental health services, reimbursement, peer support, recovery support, all those things need a Build Back Better plan, if you will, to address.
Well, we've
definitely seen an increase in the substance abuse.
Oh, yeah.
In the working well, we call them the working well in the practice. You know, these are folks who have, you know, they work civil jobs, they're teachers, and you know, we used to ask in the beginning, and then it sort of became, okay, this is my regular ongoing client. You know, they denied an issue initially.
Right.
And then we noticed that something is a little bit different. What's happening? You seem different because you have that rapport with the person. And they tell you, I've been using marijuana, or I've been, dabbling in this or that. And it's like, okay, now just scramble to find the resources because so many things are on lockdown, shut down. How do I get this person the resources that they need at this point, when this person originally did not present with this issue? So it's a little bit, it's a little bit of a shocker for some of our patients, and some we knew were already. But scrambling to find services in the height of the pandemic was really, really a struggle.
And I think too, right, is individuals are scared to go outside. People are scared. People are fearful. What are their normal coping mechanisms? What are their normal ways in which they would deal with this, whether it be exercising, yoga, meeting up with family, engaging with all of those things were just taken away. So these individuals were just sort of like, how am I going to cope? I mean, I've seen more cases of agoraphobia, during this pandemic than I have any other time in my career. And so I think that people are trying to find ways in which they can cope. And I think that that's where that substance use really just sort of gets introduced. So we're seeing new cases, we're seeing like a lot more, like high potency drugs that are being used. And so it's really just unfortunate that people, this is how people have really like dealt with it, because they don't really know what else to do. They have no other way, nowhere else to turn to.
We have a
or it's boredom, which is one of the reasons people use drugs.
Exactly.
I kind of don't blame them. We saw alcohol sales, I think, are still maintained year over year at 300 or 400%. So we have, I mean, Jonathan, you're seeing that. Remember, I think we all agree, just because people are drinking more alcohol, that doesn't mean that it's all concentrated among people who have disorders. But we can guarantee a percentage of that is misuse, which then affects all the other things in their life, their economy, their job.
So we do have a question from Jeff, I believe, and he's asking if we could discuss how the impact of COVID on interpersonal relationships can affect mental health outcomes, or how we cope with stress. So thank you, Jeff, for sending the question. I think that's an amazing question. I'll take a short stab at it. There's a treatment for depression. It's called behavioral activation. And the whole point of it is that the conceptualization of depression is that something bad happens to you and you sort of like start limiting your range of behaviors that you sort of do. So for example, before something bad happened to me and I'm a URI student, I would go read for classes in the quad. Then I would go to the cafeteria, and then I'd go to the gym at night before I go to sleep. But after something bad happens to me, my repertoire of behaviors narrows. And I'm like, I'm just gonna read from my dorm room, and I'm just gonna eat a Hot Pocket in my room, and I'm just gonna watch TV instead of going to the gym afterwards. And that model of depression basically says that that's part of the problem for why depression maintains itself. Because when I was going to the quad, I would run into somebody and talk like, hey, how are you doing? This is reinforcing, this is rewarding. When I would go to the cafeteria, I would run into other people.
Right.
Go to the gym, exercise is just reinforcing in itself. So thank you, Jeff, for the question. And I believe with COVID, what I'm scared about is that basically you're forcing people's repertoire of behaviors to narrow. We're all working from home. We're not walking around. I can't see Jeff on campus and be like, hey, Jeff, how are you? And that could influence mental health problems, just like how we had before COVID for depression. But now the stressor is relatively big and distributed amongst all of us. So thank you very much, Jeff. I think that's a very important question.
It's a great question, actually. And many of the clients that I've seen, they talk about the interpersonal impact that it's had. Many people, young people who are dating, who are very social, who maybe don't have great family support, but they've made a support system through their friends, weren't able to do all of that, and how isolating it became. That did compound it exacerbated already underlying depression and anxiety, and made interpersonal relationships a little bit weird, because I'll tell you this too. This is something that's come up. It's like, okay, so I've gotten tested for COVID, but you don't want to get tested for COVID, and so how are we going to get together? I'll say this: COVID has diminished the quality of relationships and the integrity of relationships, because people sometimes don't trust each other and trust each other to be honest through this process. Are you vaccinated? Are you not? Should I wear my mask? Are you comfortable with me not wearing my mask if we get together? Are we going to be doing this via Zoom? I mean, early on, is it Zoom? It created a firestorm of questions. And even people with young children, myself and my husband, I don't think that family, they're practicing safe social distancing. I've seen them on social media out without masks. I don't think we should be hanging out around them. I don't know what they're doing. And so we isolated a lot. And we had concerns about our 2-year-old that was born right before the pandemic, about her social skills and her ability to integrate and be around other people, because we just kept her in the house away from everyone. So interpersonally, yes, it caused a lot of damage. And the social media era was already starting that trend of people feeling isolated and glued to their phone. The other day with the Instagram, Facebook crash, right?
Anxiety went away. There was no more anxiety for like 4 hours worldwide.
Right. So everyone's glued to their phone now, because this is pretty much the only outlet that they have. And now it's become even worse, because sometimes they would go out and meet with friends, but now that access has shut down. So now we're really, really stuck inside the house and on our phones, doing some antics on TikTok from time to time. But people did what they needed to do to survive, but it did create some interpersonal deficits for sure. So great question. Thank you.
Yes, thank you, Jeff, for that question. And Jonathan, I'd like to direct this question to you, if I may. What keeps you awake at night as you have seen and studied the mental and behavioral health needs in the community during the past 1.5 years? And what has inspired you throughout this process to keep going and maintain consistent?
It's a loaded question. When you say what keeps me up at night, that used to be like a hypothetical sort of thing, but I'm like legitimately kept up at night. Like my sleep schedule has been all wonky throughout this whole pandemic. So or the syndemic, right? 2 pandemics aligning. In terms of sort of what keeps me up at night. So in order to sustain long-term recovery, be it from substance misuse, alcoholism, and also mental health issues, is SAMHSA defines the 4 dimensions of recovery as health, homes, community, and purpose, right? And all 4 of those areas were really rattled for people. And what keeps me up at night is I'm not seeing the progress that I feel like we need to make with some of those areas. Health, homes, community, and purpose. Health, that's a given. I'll put that aside. Homes. We talk about homes, and I mean, the real estate market is not even like real. It should be the unreal estate market. I just made that up. That's pretty good.
Credit you.
People, I mean, people unable to afford, or access affordable housing. Not to mention people, like, as we were quarantining, domestic violence was at an all-time high, right? So people dealing with that, like people like their homes not being the healthy place that it once was, and not being able to have access to sustainable, healthy, housing, and community. So the other 2 are community and purpose, right? And community, we're just starting to get back into the groove of that. But purpose, a lot of people find purpose in employment, right? In gainful employment. And there are still all of these barriers that they're starting to be addressed. But for example, like somebody with a felony record, right? Somebody got arrested for a felony 13 years ago. People don't realize the long-term, like indefinite impact that that has on one's ability to find and sustain gainful employment. And when you don't have that and you're not able to provide for yourself, how can we expect anybody to get well when they're not able to do so because of like their criminal background, for example? So we have seen some progress with that, particularly legislatively this year. They just signed a bill last week. The governor signed a bill saying that possession of 10 grams or less of illicit substances is now a misdemeanor charge rather than a mandated felony charge. But these, again, what keeps me up at night is that we're not, it was hard before. It was hard 2 years ago to sustain recovery, and it's just getting even harder for people. And we're not, again, as Jeff had spoken about, the social determinants of health, like we're just not addressing those as innovatively and as quickly as we need to. When you talk about timing, right, I always use the analogy of, like, in order to stay ahead, to curb an epidemic, you need to be responding and reacting quicker than that epidemic is. We are not able to do that during COVID, and we're still not doing it as well as we could.
Always ahead of us.
So just, and then the other side of that question of what inspires me, you know, throughout this process, right, is that people are still well. There are people getting well. There are people finding long-term recovery. There are people healing, families getting reunited. There are some people getting jobs, getting on their feet, being independent, and living a productive, meaningful life in society, and being a contributing member of society. So what keeps me well is to remember that, right? As healthcare professionals, typically people don't see us because they're doing well. It's like the same thing with law enforcement officers, right? Like if you're engaging with a police officer, typically things aren't well in your life, right? You're not talking to a judge in a courtroom because things are going well in your life. So we often see the worst of the worst, right? We see people at their worst, and that creates this compassion fatigue, burnout thing going on top of the compounded COVID fatigue that we're all experiencing. So I make it a point to really stay connected with people that are doing well and make sure that I build a platform for myself, that I get a front row seat to watching people get well, because it's a reminder that it does happen and it can happen for anyone.
That is very inspiring. And, you know, I know in my work with naloxone, I will occasionally talk to people who, you know, have maybe become jaded over time, having seen people, you know, particularly with law enforcement that I collaborate with, you know, they're saying that they're going to see the same people. And I really just try to stress that, you know, we have people that we connect with and work with who have overdosed many times, and they don't know why that last time was the time, but they were ready to get into recovery that time. And they can't even really verbalize what was the moment, but it's so inspirational. And, you know, I really try to advocate that we just, you know, we have to keep providing that support and intervention for people.
I'll just add this in my personal experience, 37 treatment attempts it took me before I found and maintained recovery. And if I walked in on that 37th time and the person said, oh, we're tired of seeing you, or mistreated me or anything, and gave me any reason that my disease of addiction would have taken and walked out the door with, I wouldn't be here, right? So people always met me with empathy and compassion and understanding, and it made the difference in my life. Even if it took 37 times, that's what it took.
That's what it takes. Munira, I wanted to direct this question to you. As you know, we're talking about the strain to meet the increased demand for behavioral health needs, and are interprofessional teams effective in making a difference? And how have you seen those roles on the team evolve during the pandemic?
Yeah, so I mean, I will say that, like at Butler, I think, you know, having sort of like, you know, different roles really has been very effective in being able to coordinate and treat the patient effectively. So with the way that our flow is, you know, when an individual presents to patient assessment services, they're typically seen by a nurse, and then following that, a social worker assist in sort of like coordinating, you know, like obtaining like the initial evaluation, the, you know, presenting issues and problems, There's our pharmacy team usually will sit down with the patient and, get a thorough like medication history if it's available. We have our OT team that will sort of like assist with there's any sort of like issues as it relates to sort of like gait training or ADLs and things of that nature. And then they're seen by a provider. And so, we have our medicine team who, they complete evaluations and initial H&Ps on, most of our patients that present. And so I think that one of the things that we're finding, and I will, that as we spoke about the topic of homelessness and just sort of inability to find secure housing and shelters being overcrowded and things of that nature, having that hotel open, especially for individuals who were COVID positive, was extremely helpful. Just yesterday, we had a newly COVID individual who, unfortunately, Butler doesn't have the capability of treating someone who presents for treatment if they are COVID positive. And so our disposition plan is to try to get them to our sister hospital, Kent Hospital, so that they can receive the treatment that they need. But oftentimes individuals don't want to be in a medical hospital and they're sort of like wanting to get better once they are no longer positive. And so learning that, a lot of the things that were once available are no longer available. And now we find that our social workers and our disposition team are finding it more and more difficult to find the resources for these individuals, right? And it just sort of seems like we had so much and then it just got stripped away so quickly. And I certainly understand that we're trying to get to a place in society where, like we are back to normal, but returning back to people not being able to have adequate homes and people not being able to have, like the care and the health that they need. And again, like what those 4 prongs are as it relates to being able to be stable and sustain recovery. I feel as though we've removed so much of that and it's really like starting to debilitate the patient population that we're seeing. And so as it relates to like sort of interprofessional teams, I think that we're trying harder and as much as we can to find ways in which we can utilize our skills in order to be able to provide the best options for people who are presenting. A lot of adolescents that we're seeing day in and day out. And even as Trudy mentioned, with my own children, feeling as though they don't necessarily have the social skills anymore. We're seeing kids who typically had social anxiety with school are very happy with like online learning and they were so happy during the pandemic. And so now it's like those are the kids that we're seeing so much of now because they have to return to school. They're like, I thought I never had to do this again. And, and they don't necessarily know how to interact. And so reteaching and sort of like relearning how to be social has been really difficult for a lot of people. And so those, even in how they sort of talk with you, how the interview flows and how it presents, and really just trying to, in as many ways as possible, reassure the individuals so that they can, it's the first step in being able to get better. But all of the services that we have at Butler, I think that our team, we work dynamically, we try our very best to sort of like utilize all the different minds in order to be able to provide the best plan for the patient. And it's getting harder and harder because resources are dwindling. And we're finding ourselves stuck a lot of the times.
So Hector, I wanted to address this next question to you. Certainly we're hearing substance use and overdose, deaths have increased during COVID. What are some things we can do to reverse that trend? I know your background is heavily in research and teaching, and what innovative approaches to prevention and treatment do you think need to come out of this syndemic?
To be honest, I feel like Jonathan just expressed exactly what needs to happen, and that's sort of be able to give people a life worth living and the opportunity to make that, right? Because if you don't have the ability to get your own life that's worth living, why are you going to try? And again, that sounds easy. That sounds like, oh, I'm just going to motivate you. But there's all these broad systemic factors ranging from like health insurance. What if you don't have health insurance, right? What if you don't have money for like to pay out of pocket? To like Jonathan was saying, housing, it's so expensive. Like in Providence, housing is super expensive. So again, maybe I'm wrong. Maybe there will be some sort of like magic innovative pill that will happen. But I feel from my perspective, and I could be wrong, it's sort of how Jonathan hit it just in the head. How do we give people a life worth living? And that's not just us like motivating you and giving you a pep rally, but it's also giving you the tangible things that you need, ranging from access to just basic healthcare. But again, I don't know. That's just my opinion.
And I think, you know, in just sort of hearing what you're mentioning about like healthcare, something that sort of like comes to mind is, you know, I had a family, you know, if you're a permanent resident in this country, and an adult, you typically don't have access to, you know, like Medicaid services. And during the pandemic, when you are no longer able to work for whatever reason, and then subsequently not having health care as a result of either being furloughed or laid off or whatever the case may be, it was sort of like, how do I care for my family? I don't even have access to healthcare. I can't get access to healthcare. I'm being forced to stay home. I can't even seek treatment in, you know, without getting a bill that I can't afford. And so it's like this, you know, we're creating these systems like really are affecting so many individuals on so many levels. And I don't think that we have really learned how to start to repair that, because again, you know, the cost of everything is soaring beyond what most people can afford. And that's making it really difficult for people to find purpose. When you feel as though you don't have purpose, a lot of obviously depression and anxiety that we've been talking about, but for the most part, as well as seeing, you know, all the substance use, more and more individuals, suicidal ideation with plan and intent, so, you know, actively, I can't tell you how many people I have seen in the last 18 months who have acted on their suicidal thoughts, who have followed through and have, you know, been in ICU treatment units because of the, you know, the lethality of the attempts. And again, COVID being a primary, you know, precipitant, finances being a primary precipitant, feeling as though you can't provide for your families being a primary precipitant, and then for children who are, you know, social media being on that for so long of a duration, whereas before at least we had a lot of like intermittent activities, after school activities, so many things that they were doing. Now utilizing social media, maybe there's bullying there, feeling lack of purpose. We're talking about, you know, and even now that we've had so much going on with everything that's going on with Facebook, you know, in Congress and things of that nature, but we're seeing even that there's a lot of evidence that's showing that it really can be destructive to the psyche of young girls and body image and how they view themselves, and that causing or leading to other things like eating disorders. So if your children are spending so much time on social media, whether it be Facebook or Instagram or, you know, whatever, TikTok, whatever the case may be, and that is their way of connecting to the world, if the world does not connect with them the way that they feel, you know, you never know what sort of thoughts will creep into their minds and how that will affect their day to day.
Yeah, absolutely. As the mom of a 17-year-old and 15-year-old girls, it's yeah, I definitely see that impact. Jeff, I wanted to lead this question to you. How should we be preparing the next generation of healthcare providers, given, you know, what we've learned and quite frankly, our failed dress rehearsal at the next pandemic, right? From an ID perspective as well.
Yeah, I mean, I think it's a bookend to what I said initially. Is we need to, I mean, you know, I hear other folks are parents, which means you're also teachers or you're professors or you have your precepting. You have research assistants, you're teaching peer recovery students. We're all teachers, right? In some way. And I think the thing is to, you know, role model the behavior, say, you know, I say for the last 20 years, but maybe most especially now, is don't say yes to everything, you know, focus on what it is. I mean, Jonathan talked about those 4 dimensions of recovery, but when I first heard those, I'm like, oh, well, that's just life. You know, that's right. I mean, those are all the things that sustain me. And so we're all sort of on these rungs of a ladder. Some people start out on lower rungs because of structural racism and social determinants of health and unstable health, all those other things. The pandemic has just destroyed the ladder. Like, and some people stay where they are, didn't need to climb it. Some people, we've got to really think about, I mean, all those things we've been talking about, I think about has exposed the importance of social determinants of health and financing and citizenship. All those things need to be addressed square one, right? 80% of health are those things we knew beforehand. Maybe we think it's 95 now, and maybe 1% are medications, which my pharmacy students hate to hear, that like, well, we're only affecting 1% of their life. I'm like, well, but you can refer them to care, you can provide them harm reduction materials, you can just listen to them as a visible, you know, accessible healthcare person. You know, I even talked about harm reduction today in my lecture, and I said, sometimes just saying have a good day to a person who didn't hear that, hasn't interacted with anybody, that could be enough. Pharmacies were determined essential, right? They were all open. I went to pharmacies throughout the COVID pandemic, or the current pandemic, and saw lots of things. So I think the next generation we need to duplicate this. We need lots of different professionals with lots of different backgrounds. Take advantage of Zoom. We're coming from New York, we're coming from all kinds of places. Take advantage of these things. Have students thirst for not hearing me talk all the time, right? I know that as a professor. So I bring people in to give them new perspectives. And I also try to role model. I want to hear what they're experiencing. How is the vaccine experience? How was your weekend? How, you know, we need them to realize that when you approach patients, as Trudy talked about, you know, finding out that a patient was using, or a person or a client was using substances, they found that out through that rapport. And so we need to do that in as many ways. We need to, I always say there's this fourth wall of like teacher and student, there's this lectern and it's in front of them and I'm standing and they're sitting, and I hate that. I'd rather just say, let's sit down with them. And I know you guys as providers do that. You don't, you know, sit behind your computer and not look at them and say, you know, what is your age and weight and blah, blah, blah. You interact with them. And I think that's good for us, right? Despite risks of COVID and we're all wearing masks, I think we really, like, I'm really excited to be in class this year. I didn't think I would. I thought I'd be freaked out, but I'm excited. And so being in class, being in small groups, meeting with students in my office, but getting them to work with interprofessional, and we're doing that at URI, and really saying, you know, you need to talk about your experiences, and that should help you realize that when you take care of someone else, you got, you know, it's putting on the oxygen mask and then putting it on the kid, right? The same example. You've got to be well to be able to help others and to fill in when your colleagues are burnt out and need a vacation and things like that. And then when you're burned out, you've helped your colleagues. And so we're all in this together, I think is where we need to go.
Well, we're coming up on 7 o'clock, but I wanted to ask Trudy, since I believe you're the only one of us who's out of state, I think the rest of us are all in Rhode Island. And I was curious with, you know, sort of the changing dynamics in New York City. You know, certainly we all, you know, during the time of the lockdown, all eyes were on New York City for us here in Rhode Island. And I haven't had a chance to go back to the city. It was always one of my favorite places to visit. And I'm just curious, you know, what is the perspective there? What do you see as the changing dynamics? Are healthcare professionals leaving New York City? Are they flocking to New York City? How has that changed there?
For sure, during the height of the pandemic, I think many people left. New York was like a ghost town. The New York that so many people have fallen in love with, that I fell in love with. You'd go to the city, and the city was a ghost town. Many retreated to the suburbs of the Hamptons and New Jersey, and they exited expeditiously with not knowing what was going on and having any answers. But I think what we see is the resilience of New Yorkers and the love for New York. As businesses have started to reopen and we have now access to vaccines and testing, and I think people understand the severity of what's happened, is that people are starting to come back slowly. People are starting to go back to work. Healthcare workers are starting to, I mean, they were always on the front lines, but I think that they're really starting to come back in. There's still a shortage in many areas, including still in my practice, but I find that the people are calling in a little bit more and inquiring about how they can be helpful or how they can join the team. But I think what I want to say about that is that I know we were all feeling anxious and we were all feeling worried about what was going on and we didn't know. But I think, you know, I don't know what oath people take, but I know that when I became a clinical psychologist, that my duty was to serve and to help people. And I feel like so many people dropped the ball due to fear, and I can't blame them for that. But they left their colleagues feeling very, very burned out, and left the burden to bear on the very few that were still hanging in there. And if there's, just to go back to this other question that you asked before, is what can you teach a new generation? Is even when you don't know, and as scary as it can be, you have the power to change someone's life. Again, saying hello to someone, being there to answer the phone when they're going through a crisis. We all don't know what's happening, and it's okay to say, I don't know what's going on, and I'm feeling a little bit uncertain myself, but what can we talk about today? How can I help you to feel a little bit more calm or feel a little bit more at ease? It may not always work, but at least they know that there's someone that they can reach out to. And I wanted to be that during the pandemic, as scared as I was and as confused as I was. So hang in there even when things get tough. I'm sure many of you hung in there. So many other people did. I don't want to discredit that, but so many people did just run at the opportunity that they could, and have still had resistance in coming back. And that can really change how people view those who are supposed to take care of them. If you're running, then I'm running scared too. But it's okay to say I'm afraid, but I'm here with you. Let's be together through this. Let's figure this out together. So I don't know if that answered your question, but it answered the question before just a little bit.
I think you answered both questions. That was perfect, and that was actually, I think, a wonderful and sort of beautiful closing to our panel tonight. I just want to say, thank you, Munira, Jeff, Hector, Jonathan, Trudy. I'm honored to have been your moderator for the evening, and I'm glad that we were able to get to all of our questions, and we don't have any additional questions from the audience. So I would like to just remind people that we will be having 2 more of these webinars on October 20th. It will be focused on COVID and children, and then our final panel on November 3rd will be looking at the critical role of healthcare teams in supporting COVID patients with complex pre-existing conditions. So thank you all for being with us tonight. You're all inspirational, and I feel like I learned a lot and really enjoyed being part of this evening. Thank you, everyone.
Thank you for having us.
Thank you. Great meeting you all.
Bye, y'all.
Bye-bye.